Okay. Okay, so this is LU5, okay, surgery 250. So we'll have a case presentation and discussion. So 10 to 12:30. If you can finish in 2 hours, so much the better. Okay. Okay. So all of you are present. Joy B, Janine, Noreen, John Patrick, Austin, Arrest, and Michelle Lau. Okay, 7. Then, okay, I'll just modify the learning objectives a bit now. Okay, but essentially it will be the same. It will just reinforce the learning objectives given to you by the college. Okay. So given the patient, the students, the mentees present the case and discuss the clinical management using the rational and cost-effective processes, patient management process. So in this particular teaching, I like to focus on teaching you how to do the rationalization and also the basis for your decision making. Because basically, management of a patient is problem solving, decision making. So you should be rational, you should be effective, you should be efficient and compassionate in your decision making, problem solving, decision making, which is seen in the one that I gave you. Okay, patient management process and overview. Okay, it's seen in this YouTube. I hope you have seen the YouTube. Okay, I gave it to you. So this is the patient management process. Okay. Just take a quick look. We will go back to this later on. Okay. Just an enlargement of the first one. So you'll be taking focus, history, and physical examination, pertinent negatives and positives. Okay. That will lead to the diagnosis. Then you come out with the primary working impression, and differentials. The differentials will be your secondary. Primary is the most probable. Secondary will be the second most probable. So you don't have to give 10 differentials, 12 differentials as the usual practice, because that's not an efficient way of doing things. Okay. And then plan of management, diagnostics, and preparations. So formulate a plan of diagnostic workups to confirm the primary impression according to standards of care. So you can see here, when you do your diagnostic workups, you focus first on your primary impression rather than trying to make sure that all the differential diagnoses are covered. No? The focus is on the primary impression. Plan of management, okay, what therapeutics or surgery. Okay, so decide on the plan, whether surgical or medical. Okay, and explain the rationale. And then post-op, since we are in surgery, post-op complications, prognosis on surveillance. Okay, so this is part of it will be how to explain to the patient, how to advise the patient on health management, health restoration, and then surveillance, since we're dealing with cancer here. No? Okay. So is that clear?
Yes.
Okay. So I don't have a copy of how I'm going to grade you. I suppose I have to grade you also, right? Right? Am I supposed to grade you or no more?
Yes, po.
No more grading?
Meron po.
Meron? Meron o wala? Noreen? So we will...
Meron po, sir, but hindi pa po nabigay grading sheet po sa amin. I'm not sure if sa end niya po ibibigay.
I suppose meron yan, no? So, okay. Anyway, I'm supposed to take a look at your grading sheet so that it's fair for me to do things that I should do to grade you. Okay, but anyway, I'm going to grade you based on the demonstration of the patient management process. Okay. I have given you a write-up, YouTube, and also some PowerPoint. Now, I suppose you have read it. Now, it may be something new to you, okay? Because, but I've been teaching that since 2085, 86 now, the patient management process. Anyway, I gave you a handout. Try your best to follow the framework. Okay. So this will cover the history, physical examination, differential diagnosis, diagnostic, and treatment. Then you will be graded on the case that you're going to present. You're going to present through a PowerPoint, I suppose. And then another part of the grading will be active participation. Okay. So as much as possible, I'll be grade you on the individually, okay, based on active participation and also your presentation here. Then at the end, I will be added learning will be I will be asking you to take this OLETE online learning COM evaluation test exercise. There's a link here. Okay, so you just click on the link. It's sort of a objective type of questions. Okay, so you just take it, then perfect it. Okay, so first try. If you don't perfect it, you just take it again until you get a perfect score. Okay, that's why it's called learning COM evaluation test exercise. No, okay, so that's part of the grading. No, so it's up to you whether you want to perfect it. If you don't like to perfect it, then you don't get a big bonus score for your grade. No, okay, but at least try to take it. No, okay, clear? Is everything clear? Any questions?
Yes po, sir.
Okay. Okay, so what we're going to do, it's 10:07. So I'll just let you present the case. Although I went through the paper that you submitted. No, okay. So, but I think you prepared a PowerPoint, right? A slide presentation. Okay, just go through it. Then I won't ask any questions. I'll just take down some notes. Then we will get back to the case and discuss it in more details. Okay, is that clear? Okay, go ahead.
Yes po, sir.
Yes.
Sige po, sir. Let me just share the slides po. Are the slides visible na po?
Yeah.
Okay. Sige po. Okay na po, sir. Sorry, I didn't quite hear.
Go ahead. Go ahead.
Okay po, sir. So, good morning po. So, this is our presentation po on breast preceptorial, one of our patients. So, again, I'm Austin po, sharing the screen with my group mates po, Javier, Huachon, Humawit, Lacerna, Nakato, and Lau. For the case background po, Janine.
Hello. Okay. So first for the case presentation. So next slide, please. Okay, so this is the case of MJC, a 50-year-old housewife from Quezon City, coming in for the chief complaint of breast mass. Next slide. Okay. In April 2021, the patient felt a discomfort over her right breast. And upon probing, she just explained it as parang she can't explain it now, it's more of a gut feeling. And then she noticed a faint scar, which was approximately 2 centimeters, so a faint scar-like mass over the inframammary fold at the lower inner quadrant of her right breast. This prompted teleconsult. However, it was ruled out to be a benign condition by the doctor, and her doctor gave her unrecalled antibiotics. In February, so this was left for 1 year, approximately 1 year, and then in February 22, the patient noticed a foul smell emanating from her body. So the scar-like mass on her inframammary line, she noticed that it progressed into a red-colored open wound that was larger in size. So now it was approximately 4 centimeters. It was immovable and with indistinct borders and non-tender. Upon wiping with a cotton ball, she noticed that it had blood and pus, but no other symptoms were noted. This again prompted online consultation. And then in March 2022, she was advised to go to BCC in PGH for checkup, where ultrasound and mammogram were done. Results of the diagnostic procedures were unrecalled. However, we can surmise that the mammogram results may be around BIRADS 4A to 5 because in April 2022, core needle biopsy was done on the open wound or the scar, and it was revealed that the patient had invasive breast carcinoma of no special type and stage of 3B. Immunohistochemistry was subsequently done, and it was revealed that the patient had ER/PR positive and HER2 negative. Then in July 2022, the patient started to do chemotherapy with doxorubicin and cyclophosphamide for 4 cycles, and then docetaxel for another 4 cycles. So the patient had a total of 8 cycles. Afterwards, it was noted by the doctor that the patient had reduction of her tumor, and it was mentioned to her that it was almost not palpable. Then, 1 day prior to consultation, the patient was admitted for a modified radical mastectomy of her right breast. For her ancillary history, for her past medical history, the patient had spinal surgery in 2001 due to a fall accident, but otherwise she had no other comorbidities and no allergies. For her family medical history, she has a history of cancer. So on her paternal side, there's leukemia, and on her maternal side, there's brain cancer, and most importantly, ovarian cancer. For personal social history, she denies any vices, but she mentioned that she is constantly exposed to secondhand smoke due to her partner and daughter smoking inside their home. For her menstrual history, we noted that her menarche was at 16 years old, so it wasn't too young and not too old. For obstetric history, in 1994, she gave birth at 23 years old to a full-term female baby. So her first pregnancy wasn't when she was too old or too young. She also had a history of oral contraceptive use for 5 months, and then she switched to injectables, which she continued for 3 years. For her review of systems, she had no weakness, fatigue, sleeping problems, or disturbance in appetite. However, she noted nail discoloration, nail pitting, muscle soreness in all extremities, finger movement limitation, and numbness of extremities, as well as tremors in bilateral lower extremities, possibly due to a remnant side effect of her chemotherapy.
For the physical exam, the vital signs are within normal limits. For the anthropometrics, we noted that the patient is overweight with a BMI of 23.6 according to the Asian criteria. And then for the systemic physical examination, we noted these pertinent negatives and positives. We noted that the patient has alopecia, which may be attributed from the chemotherapy. The patient has anicteric sclerae, pink conjunctiva, and no discharge. The patient also has no signs of bleeding, paleness, cyanosis in the oral region, and then there's no lymphadenopathy and non-palpable thyroid. For the chest and lungs, the patient is eupnic and with clear breath sounds, with a dynamic precordium, normal sinus rhythm, and distinct heart sounds. For the abdomen, it is globular and non-distended, no visible veins or scars. It has normal active and non-tender abdomen. For the extremities, we noted the patient has a total melanocytia and multiple Merck lines, which may be attributed to the chemotherapy. The CRT cannot be assessed due to the nail changes, and the patient has no edema in all extremities. For the skin, the patient is warm to touch with no discoloration. We noted that there's a 5-inch skin-colored raised, well-defined keloid scar at the left upper back, which was attributed to her previous surgery. And then for the MSK, the patient is ambulatory. And for the breast exam, Next slide, please. For the breast exam, for the inspection, we noted that the patient has asymmetrical breast. There's no noted pure orange and dimpling and discoloration of both breasts. And then there's no spontaneous nipple discharge. And next slide. For another inspection, we noted there's a puckering at the lower inner quadrant at the right breast. There's also multiple brownish, well-defined irregular shaped ulceration on a 7 by 5 centimeters erythematous base at the right lower inner quadrant in the inframammary area. For the palpation, for the right breast, we noted that there is 2 by 3 centimeters non-tender, rounded, movable mass at the upper outer quadrant, estimated at 9 o'clock to 12 o'clock position, which is 1 centimeters away from the nipple. There is also a 7 by 5 centimeters non-tender, immovable, matted ulceration at the lower inner quadrant, estimated to be 4 o'clock to 5 o'clock position at the inframammary area. There's no nipple discharge, spontaneous and non-spontaneous, and there's no noted axillary lymphadenopathy. For the left breast, there's no lesions have been observed and no palpable mass. It is non-tender and no nipple discharge, even with the spontaneous and non-spontaneous, and then no noted axillary lymphadenopathy.
Okay, so moving on to the case management. So first, for the clinical diagnosis, our primary diagnosis is primary breast malignancy, and to present our rule and factors of Austin. Okay, so first going prevalence based. Okay, so here are her risk factors. So first, her age and sex. So breast cancer is the most common cancer in women, with an approximate female to male ratio of 150 is the one. And it was also reported in the previous study that the median age among Asian population of at the time of breast cancer diagnosis is 49 to 50 years old. So our patient fits that criterion. And also another risk factor is the family history of other cancers. So as mentioned, the patient has a family history of different cancers. And this is significant because some patients may have a higher risk of developing breast cancer. One particular cancer that has been shown to have a great hereditary risk to developing breast cancer is ovarian cancer, which, as mentioned, is present in her family. And this is because ovarian cancer and breast cancer both have a genetic link. So it's BRCA1 and BRCA2 gene mutations. So they both these mutations can both cause can cause both of those cancers. And of course, being genes, they can be inherited. Next is her history of contraceptive use. So different studies have contradicting results, but some research have found that women who have ever used OCDs have a slight increase in the relative risk of breast cancer development compared to women who have never used them. And a possible explanation for this is because those contraceptive pills, which contain synthetic sex hormones, they may stimulate the development and growth of cancers that express receptors for them, such as the case of breast cancer. Next, failure to breastfeed her child. Researchers have found that mothers who did not breastfeed had a higher chance to be diagnosed with premenopausal breast cancer. So there's no defined explanation for this, but a possible mechanism could be due to the fact that breastfeeding induces hormonal changes that can delay menstrual period of the mother. And this thus reduces her lifetime exposure to hormones that can promote breast cancer cell growth. Next is exposure to secondhand smoke from her partner and daughter. So more recent studies are showing that secondhand smoking may after all increase the risk for breast cancer for never smokers. And this is very similar to other cancers because cigarette smoking may play a role in failure of DNA damage repair. And next is her educational attainment. Research has seen a direct correlation, so note it's a correlation, not a causation, between educational attainment and breast cancer risk. So there was a particular study among Filipino women which found that the odds ratio of finishing vocational school and tertiary education, they both have an odds ratio of 1.9. This is in comparison to those who finished elementary school. They only had an odds ratio of 1. So those are the prevalence-based factors that made us rule in primary breast malignancy. Next slide. So for the pattern-based, so these are the pertinent physical examination findings and history findings that we noted. So her symptoms, so similar to other breast cancer cases that we've read, so it was initially asymptomatic. So we kind of noted that it was an incidental finding on her part. So it was an incidental finding. And then her symptoms progressed. So over time, she noticed the breast asymmetry, the thickening and puckering over her inframammary line that grew over time, a foul-smelling discharge, ulceration, fixation to the chest wall or immobility, and erythema of the skin of her breast. So they all point towards a breast malignancy and even indicate a locally advanced disease. So those are the pattern-based factors for the first diagnosis.
All right, so moving on to the secondary diagnosis. For the secondary diagnosis of this case, it's going to be breast cyst, and it's primarily due to the mass found in the right breast of the patient. Next slide. For the prevalence-based, first we have age and sex, and then second we have oral contraceptive use. So the risk of benign breast diseases is often associated with age and hormonal factors. And while the etiology of breast cysts is currently unknown or hindi pa super clear, most breast cysts are associated with the aberration of normal development and involution. So for the age and sex, breast cysts have already been found to occur more commonly among premenopausal, perimenopausal, and postmenopausal women, with the peak incidence between 35 and 50 years of age. So for the patient, when she was asked if menopause na siya, she mentioned na parang it's been 3 months pa lang since hindi siya dinadatnan. Pero kasi she would attribute it then to yung chemotherapy niya kasi it's not the first time naman na hindi siya nagkaroon ng menstruation in the past few months. So while they can be found in women among any age group, the most occurrence have been studied to be among women before menopause, with a note of prevalence among postmenopausal women, especially those undergoing hormone therapy. So benign diseases such as breast cysts have also been found to be more common among women compared to men. So many studies report a high lifetime prevalence of fibrocystic disease in women, showing that over 70% of all women develop fibrocystic changes during their lives, with 20% of these women being symptomatic. And among the fibrocystic breast diseases, it is said that breast cyst is the most common, with around 77% of all women developing a palpable breast cyst at some point in their life. Moving on to the next one. So we have oral contraceptive use. No, not yet. Sorry. So for oral contraceptive use naman, the patient has a history of contraceptive use, as mentioned. It is said that hormonal function and fluctuation directly influence breast cysts and their associated symptoms. So this can also explain why breast cysts typically occur during menstrual cyclic changes, as well as lobular development and involution as seen in premenopausal and perimenopausal women, as well as postmenopausal women. So currently, there are studies that suggest na actually may protective factor daw yung contraceptive use sa development of breast cysts. However, there are more recent studies then that also suggest na may positive association between contraceptive use and breast cysts. So medyo may contradicting ano pa siya, results. But again, it's important for them to take note of this as there are studies that suggest na the positive association. And typically, because of the hormonal fluctuation, you would expect na most benign cysts disappear and then new cysts develop after a year after menopause. So, next slide, please. For the pattern naman, the patient presented with discomfort over her right breast and smooth, firm, and discrete mass, so which are typical presentations of your breast cyst. However, yung mass of the patient was noted to be non-tender and had like indistinct border also, which are usually not the case pag breast cyst yung diagnosis natin. And then again, as mentioned, the patient is in possibly in her premenopausal or perimenopausal stage. So we would expect then increased occurrence of benign breast disease such as your breast mass. Next slide. So, okay.
Hello, sorry. So I will proceed with our paraclinical diagnostics po. So next slide. For our paraclinical diagnostics, for our primary and secondary clinical diagnosis po, so we, as mentioned by Janine and Rick po, we are highly considering a primary breast malignancy, 90% certainty. So we're quite certain that it is a primary breast malignancy given how the patient presented po. And the treatment modalities for that are surgical management, radiotherapy, and chemotherapy po. We're quite certain it's primary breast malignancy because on admission to PGH, she was diagnosed po nga with breast cancer of the right breast stage 3B po. And she also already presented to PGH with her diagnostics such as her ERPR and her HER2 po. Although we are still considering a breast cyst po. Only slightly certain po. So if it does turn out to be a breast cyst, the treatment modality for that is a needle aspiration po. So next slide. So I'm just going to mention recommended diagnostic procedures for when a patient presents with a suspected breast malignancy po or a breast lesion po without any prior diagnostics yet po. So for those po, we have a core needle biopsy, the HR and HER2 status, a mammogram, a breast ultrasound, an MRI, a complete bone scan, and the CT of the chest and abdomen. So we'll get into each one of those in the next few slides. So next slide po. So first of all, we recommend the core needle biopsy because it has high sensitivity for diagnosis of breast lesions. The risk associated with a core needle biopsy is that it is an invasive procedure that may cause hematoma in less than 2% of patients and discomfort to the patient, of course, since they're going to have to be anesthetized and, be in the OR also. So given the cost that we searched for here, it averaged about 3,600 pesos in government hospitals here, and it's widely available. Although it depends on whether or not there will be a doctor available to conduct the biopsy po. So next po, another recommended procedure is the HR or the ERPR status and the HER2 po. So this, after determining whether or not it is a breast malignancy, knowing the HR status and the HER2 status po will dictate the therapy to be used in the patient, and it also indicates to an extent the patient's prognosis. This is a relatively low risk procedure, although it is quite expensive. Even in government institutions, what we found is that it averages around 3,000 for the ER, 3,000 for the PR, and 4,000 pesos for the HER2, giving a grand total of 10,000 pesos for this assessment. Although it is quite available, it's not available in all government hospitals or all hospitals in the Philippines. It's available in a lot of the bigger ones and in selected hospitals po. So next is the mammogram po. This is a standard procedure, and it is also recommended by the clinical practice guidelines of the Philippines po. So regular mammograms can help in the early detection of breast cancer po, which is why it is often recommended for women older than 50 and can also be coupled with a breast ultrasound in order to better increase the chances of screening for breast cancer po. Although the risk that comes with the mammogram is radiation exposure, and I think from experience and from what I heard from people, it is also a very uncomfortable procedure for the patients, but since they would have to manipulate the breast a lot in order to get a good reading on the mammogram. And the cost of this among government hospitals here is 1,500 pesos, and it's widely available in the Philippines. So next slide. So along with the mammogram, the next recommended diagnostic procedure of the Philippine Clinical Practice Guideline is the breast ultrasound naman po. So it documents lesion characteristics, and it's usually coupled with the mammogram. Although in women younger than 30 years old, it's recommended that women get only the breast ultrasound and then the mammogram next time when they're older. So the breast ultrasound can also guide a biopsy. There are a lot of ultrasound guided biopsies, especially for core needle biopsy or fine needle aspiration biopsies, but for breast tissue. And for the breast ultrasound, it's relatively low risk, although the downside of it is that it's quite operator dependent. So whether or not you can visualize the lesion also depends on whether or not the operator is skilled. So the cost of a breast ultrasound among hospitals here is about 1,450 pesos, and it's widely available. So next is the MRI naman po. So this procedure is useful for staging. It's useful for staging a potential breast cancer, and it also checks for the presence of multifocal or multi-center cancer po. So it's also used for evaluation before and after preoperative systemic therapy to define the extent of the cancer and its response to treatment. So that's after preoperative systemic therapy. And it also assesses for the potential of breast reconstruction therapy po. So the risk is, since it's an MRI, it's magnetic, it may not be able to be used for patients with implants, especially metallic implants. So another downside of it is the cost. MRIs here are quite expensive. So in some government hospitals, we've seen that they average around 8,000 pesos, and they are available not in all hospitals, so in selected hospitals only. So next. So lastly, for the complete bone scan po, this may be recommended to evaluate for bone metastases. So yeah, we can use it to evaluate for metastases po, and if the breast cancer has advanced to a higher stage, that's when it's probably recommended. And it's a relatively low risk procedure, although it's quite expensive also at an average of 7,980 pesos, and it's available in selected hospitals. And lastly, for the CT scan of the chest and abdomen, it's also to evaluate for Mets, and usually this is when the patient is suspected to have metastases into the lymph nodes or into the surrounding organs po, and the risk for a CT scan is the radiation exposure that comes with it. So for a chest CT, the average is 3,500 pesos, and for the whole abdomen, it's 5,500 pesos. And it's available in selected hospitals here and also in the Philippines. So,
Sorry, naglalag lang po yung Google Slides. So I will have to reshare. So, ano po, is it visible na po again? Sorry po.
Yeah.
Okay, thank you po, sir. Next slide.
So, we'd like to explain why we think it's a 90% certainty of primary breast malignancy and 10% certainty for breast cysts. So, as you can see, there are a lot of factors in the patient that could rule in primary breast malignancy. So to summarize what has been discussed by my groupmates, the patient is a female, 50 years old, with a family history of other cancers, a history of oral contraceptive use, a failure to breastfeed her child. She has exposure to secondhand smoke. She currently has breast asymmetry in her physical examination, a thickening and puckering of an inframammary line. There's foul smelling discharge, a fixation to the chest wall, ulcerations, and erythema present. With this, in comparison to breast cyst, she has a history of oral contraceptive use and a smooth, firm, and discrete mass. However, there is a chance for ruling out breast cyst because of the tender mass with a distinct border. With this, next slide, please. We are chosen paraclinical diagnostic procedure out of all these to confirm and diagnose primary breast malignancy is core needle biopsy. Although it has risks of hematoma, it's only at 2%, and another disadvantage would be discomfort to the patient. However, this diagnostic procedure would correctly identify benign and malignant diseases in more than 90% of cases. So it has a high sensitivity of diagnosis of breast lesions. So it can tell whether a disease is a mass is a cyst, or if it's malignant, or if it's an infection. And additionally, if ever the mass is proven to be malignant, the specimen can be further submitted for testing for ER, PR, and HER2. So it's more cost efficient that way. So if we move on to the next slide. Here are the procedures done on the patient according to her results as well. So as we have mentioned before, she needed a core needle biopsy to confirm her diagnosis. So on her right breast, it was found out that she had an invasive carcinoma of no special type. So invasive ductal carcinomas of no special type generally have a worse prognosis in comparison to special type breast cancers. And this is because although it's the most common type of IDC, occurring in 40 to 75% of all invasive carcinomas, it's actually due to its wide variation of tumor tissue. So they can vary in shape and size, and differentiation can either be up to 70% of the tumor tissue to complete absence. So it's quite an unpredictable type of cancer compared to special type breast cancers, wherein a lot of it is differentiated and distinct. Next slide, please. So we also have an ERPR and HER2 immunochemistry diagnostic procedure. So the results were she was positive for estrogen receptor assay and positive for progesterone receptor assay and negative for HER2. So in this case, the patient is Lumina A, and with this, it has a better prognosis compared to other types of breast cancer that are ERPR negative and HER2 positive or triple negative. So this is because estrogen receptor and progesterone receptor positive types of breast cancer indicate that the cancer can be responsive to tamoxifen and other endocrine therapies. So it has also been observed in studies that a negative HER2 result is associated with better prognosis compared to a positive HER2 result. Next slide, please. So the patient was also had also undergone a CBC with differentials. So the main takeaway from the results is that she has low red blood cells, hemoglobin, hematocrit, MCV, MCH. So in the next slide, we can interpret. Next slide, please. We can interpret that she has anemia, and this could possibly be an anemia of chronic disease, and also it can also be attributed to chemotherapy, since it reduces the rate at which blood cells are produced in the bone marrow. And then since her neutrophils are also decreased, so this could also be attributed to her chemotherapy. Next slide, please. So she also had results for creatinine. So she had her first creatinine level testing at January 25, which is in the normal value. And in her next was during this was supposed to be February 8, 2023 with increased creatinine values, but this is still within normal range. So for the interpretation of this po, we can say na her creatinine values may be attributed to her chemotherapy drugs, since she's been taking, aside from that, she's been taking a lot of chemo drugs, and since it's still in the normal values, so kidney injury can still be, it means that kidney injury is not pertinent in the patient po. And then the next slide, please. So the patient has also undergone a CT scan of her chest, and as mentioned before, it's important for detection of metastasis. So here are the results. There is no evidence of gross pulmonary mass or mediastinal lymphadenopathies. Lung findings present a previous inflammatory process, evidence of previous inflammatory process. And then she also has a mild form of cardiomegaly in the left ventricular side. And then she has atherosclerosis, sclerotic focus, which is worrisome for a metastatic lesion, thoracic spondylosis, T12L1 fusion, and right thyroid lobe nodules. So in the next slide. Next slide, please. So we can interpret her CT scan to that her cancer has not metastasized to her lungs or mediastinum yet. And she has a possible history of respiratory tract infection. She has left ventricular hypertrophy with a possible association with atherosclerosis. And her sclerotic focus in the spine could be a possible metastasis metastasis, although she has mentioned that she's had a spinal injury before, but it's also important to take note of this, since breast cancer generally metastasizes to the bone with a high affinity for the vertebra. And then for her thyroid, she has nodules, and although this is rare, breast malignancy, thyroid metastasis secondary to breast malignancy is also significant for her prognosis and survival, since it's also important to correlate this with ultrasonography and if possible confirmation with biopsy and immunohistochemistry as well. So next
So
slide.
our pre-treatment diagnosis, on admission to the PGH, the patient was diagnosed as a case of breast cancer of the right breast, stage 3B, status post neoadjuvant chemotherapy, and the patient's cancer is ER/PR positive and HER2 negative. So the patient was also diagnosed with anemia, most likely due to the chronic disease, and status post spinal surgery from a fall, which was 2001. So for the goals of treatment for the primary diagnosis, the first goal is to reduce the size of the tumor and reduce the risk of any cancer re-emerging in the patient. Other goals include reducing the risk of complication and development of adverse effects of treatment modalities, reduce patient morbidity and maximize quality of life, and reduce risk of acquiring iatrogenic diseases. For the management options, so chemotherapy is used to maximize distant disease-free survival, whereas radiation therapy is used to maximize local regional control and disease-free survival. Preoperative chemotherapy followed by breast-conserving surgery and radiation can be done in patients with stage 3 to achieve a low local regional failure rates. Moreover, in the December 2022 Philippine Breast Cancer National Clinical Practice Guidelines recommends patients with PR positive breast cancer patients to receive an adjuvant hormonal therapy, which includes a tamoxifen with or without ovarian suppression or ablation, or aromatase inhibitor with ovarian suppression or ablation. Another treatment is the adjuvant radiotherapy in post-mastectomy patient who underwent neoadjuvant chemotherapy. Is recommended for patients presenting T3 or T3, T4, or node-positive diseases. For breast cancers deemed invasive, a total mastectomy with surgical axillary staging is recommended. Breast reconstruction should be offered to all women, including those who may need therapy. Partial mastectomy with whole breast radiation may be offered, but further surgery is recommended if margins are positive. In August 2020, Philippine Society of Medical Oncology consensus recommendations for breast cancer in COVID-19 era also recommends the prioritization of surgical management within 4 to 8 weeks among patients who completed neoadjuvant chemotherapy. So for surgical options, given the clinical background of the patient, a modified radical mastectomy is recommended in order to reduce cost, ensure likelihood of remissions, and is safe for good 5-year prognosis, which only 6% experience return of cancer. Adverse effect of this surgery is the formation of seroma, pain in chest wall, brachial plexopathy, skin lesions, and peripheral lymphedema. So next slide. For the treatment modality, for the preoperative chemotherapy, so doxorubicin and cyclophosphamide, it is the first to 4 cycles. We saw that the benefit is seen in the RCT comparing the dose-dense AC or doxorubicin and cyclophosphamide with or without sequential paclitaxel. They have better disease-free rates among patients with axillary node positive breast cancers. And then this is that there's a bone marrow suppression, increased risk of secondary malignancy, and it is also associated with significant cardiac toxicity. For the cyclophosphamide, with the prolonged use, it may cause hemorrhagic cyst disease. So the cost, The doxorubicin, it's 549. So times 2 vial per cycle times 4 cycle. And then the cyclophosphamide, it's 220 times 2 vials per cycle times 4 cycles. So the total is 6,159. This is from the DPRI. And then it is mostly available to 18 to 20 hospitals in the country. For doxetaxel, the benefit, this is for the 5 to 8 cycles. So the benefit, it has both the disease-free survival and the overall survival were highly significant when AC, the one we mentioned before, the doxorubicin and cyclophosphamide, followed with this docetaxel, every 3 weeks, it shows a better, significant higher disease-free rates and overall survival. So the risk, it may have side effects, which is increased fluid accumulation. It also has dose-dependent pulmonary toxicities, acute bilateral interstitial pneumonitis, which is demonstrated to occur before, during, immediately following, and even after the initial administration of the drug. So the cost of this drug is 1,908 times 4 cycle. It's a total of 13,794. It is also widely available in 18 hospitals in the country. So as mentioned before, adjuvant hormonal therapy for the tamoxifen, it's either tamoxifen or aromatase inhibitor. So for the tamoxifen, with or without ovarian suppression, the benefit shows that so there's no insufficient data that supports routine addition of ovarian suppression and ablation to tamoxifen. It shows that in the RCTs that either tamoxifen or exemestane among premenopausal women have undergone surgery for HR-positive breast cancer demonstrated no significant difference in the disease-free rates. So between tamoxifen with ovarian suppression and tamoxifen alone, they have no significant difference. So routine ovarian suppression is not recommended. For the risk, the tamoxifen is associated with endometrial hyperplasia and polyp formation, though this is benign and not life-threatening. So the cost is 7.8, and it is widely available in 20 hospitals in the country according to DPRI. So aside from that, we can also choose aromatase inhibitor with ovarian suppression or ablation. So the use of this with or without ovarian suppression was studied in 2 RCT, where premenopausal women with HR positive were assigned to either regimens for 5 years. So it was the result shows that exemestane plus ovarian suppression demonstrated a significant prolonged disease-free rate, which is 92.8%, when compared with tamoxifen plus ovarian suppression, which is 88.8%. While there's no significant difference between observed in the overall survival between the 2 groups. So based on the result of the trials, the use of tamoxifen alone and aromatase inhibitor with ovarian suppression are recommended for premenopausal women with PR positive invasive breast cancer patients. So with the risk, the common side effect is the joint symptoms such as arthralgia, and then we also found out that estrogen suppression, adding by the aromatase inhibitor to oophorectomy or ovarian suppression, they showed that it produced excess of early deaths from coronary disease, suicide, depression, or other mechanism. So for the cost, some of these drugs are not in DPRI. The one in DPRI is letrozole, which is 32.98 pesos, while from our online research from Watson's, anastrozole is 106.5, and exemestane from Watson also is 326.75. So the letrozole is only available in 2 hospitals and some pharmacies. So other medications were also can be also considered like the filgrastim, metoclopramide, and dexamethasone for the after chemotherapy. So next slide. So this is the post-chemotherapy status of the patient before going to operation. So as patient said na di daw nakapa nung doctor before so parang di na daw nakapa yung bukol dun sa site, which is on the right side. So we also tried to palpate. We didn't palpate the tumor that she mentioned before. So we just only noted the erythemus, the lesions, but no, as she mentioned, she had a foul smelling odor before and bleeding now. Wala na siya, so it's completely healed. But there's noted puckering at the right lower inner quadrant in the inframammary area. Next slide.
Okay, so for the surgery of the patient, so to reiterate what Noreen and Joyby said earlier, so the patient was stage 3B. Prior to chemotherapy, her staging was T4N1M0. Then post chemotherapy, her staging became T4N0M0. So T4, to reiterate lang po, T4 is kapag the tumor extends past the skin and may invasion of the chest wall. And one for the patient is metastasis to the ipsilateral axillary lymph nodes, which is nung sa second po na TNM staging niya, post-chemotherapy, naging N0, so no lymph node metastasis was detected na po. Then no metastasis and no distant metastasis M0 for the patient. So for surgical options of the patient, so there are different types of mastectomies that are used in modern breast cancer surgeries. So they include yun nga po, the modified radical mastectomy, simple total mastectomy, skin sparing mastectomy, and nipple areolar sparing mastectomies po. So for our patient po in particular, when we were talking with the patient regarding her treatment plans, because prior to chemotherapy, she was already advised the modified radical mastectomy because of the lymph node metastasis. So previously po, yung other, parang originally po, ito na po yung plan ng patient because it was what the patient wanted from the get-go. So when we asked the patient if part and part, since because of the clinical practice guidelines, if she wanted breast reconstruction, she said that because of like cost concerns and parang personal choice na rin po mismo ng patient, hindi po siya nag-aayon ng breast reconstruction. And yun nga po, medyo depleted na rin po yung finances ng patient. She said the modified radical mastectomy really was her choice from the get-go in terms of surgical post-chemotherapy. So for the modified radical mastectomy po, it implies removal of the breast tissue, underlying fascia of the pectoralis major muscle, and the level 1 and 2 axillary lymph nodes. So as mentioned earlier, when she was planning her treatment, her lymph nodes, her stage 3B considered axillary lymph node metastasis, so N1. So the survival rates of MRM are equivalent to the radical mastectomy, the one it's based off of. Though the Halsted mastectomy isn't really performed as much anymore. It's more of a legacy procedure because of advancements, and equal naman siya. Pero hindi na, in terms of morbidity, MRM at saka mortality, MRM has lower rates of morbidity and mortality. So as mentioned earlier by Joy, a surgery using MRM, complications include the seroma formations, as well plain, brachial plexopathy, peripheral lymphedema, and wound infection. So again, as mentioned in surgery, 8 weeks after neoadjuvant chemotherapy. So it reports are so 8 weeks because it's around 8 weeks na po since the last dose of chemotherapy of the patient on January 6. So ngayon po, parang ang reported rates po, 5-year survival depends on which parang study you cite. It ranges from as low as 85 to 96% po. So with this po, I think we believe that post neoadjuvant chemotherapy, modified radical mastectomy is the most cost-effective and the most efficient surgery to be used on the patient. So ito rin po yung nagawa po sa patient. So yung post-operative status po ng patient after undergoing the modified radical mastectomy, ito po yung naging post-operative status ng patient when we met with them post-op. So the patient first was not in pain. So may pain medication po siya for pain control. The vital signs po were stable, pulse rate of 98, respiratory rate of 20, blood pressure of 100 over 60, O2 saturation of 99%. Tapos immediately po, patient was already ambulatory, though there's noted a GP drain po of the right axillary area post-op. So in terms naman po of the parang pain medications she is given, I think post-surgery parang ngayon na po, she's only given a paracetamol and tramadol for the pain relief. But otherwise, no complications po were noted po with this patient. So, yung post-operative status po, yes, paracetamol, tramadol for pain. So, treatment of moderate to severe pain. Though there's a risk of drug dependence with the tramadol. The cost naman po is not available in DPRA, pero sa Watson, so nag-check po kami, it's around 29.25 pesos per tablet po. She's also advised po celecoxib, PRN for pain and the inflammation po. So, though yun nga po, risk factor for celecoxib is cardiovascular mostly. The cost naman na po is around 3.4 pesos per tablet. Then available naman po siya, very more or less available po siya. 50 hospitals in the country and sa mga pharmacies din po. So other instructions we were able to give with the patient were wound care po, to protect the incision from external contamination, protect healing tissue, and prevent infection of the incision. Then the follow-up for the patient is on February 28 daw po at the breast clinic. So, ano po, according po to the guidelines, post-mastectomy radiotherapy is recommended since in post-mastectomy patients na nag-undergo na po ng neoadjuvant chemotherapy, radiation is recommended for patients presenting with T3 or T4 stage or node-positive disease. So as mentioned earlier, the patient was initially seen as T4N1 when they were guiding the choice of treatment. So the reason for this po is that yung post-mastectomy radiotherapy, it reduces risk of local recurrence of the breast cancer. So since medyo mataas na po yung risk nung patient, since invasive ductal carcinoma tapos T4 medyo may invasion na po of the chest wall, the radiotherapy was very much indicated for this patient. Low risk nga po of acute toxicities to the involved area are always there, such as skin fibrosis, muscle weakness po of the pectoralis, and pulmotoxicity in particular, since right breast po yung radiotherapy sa patient. But it reduces risk po of local regional recurrence from some studies cite po na if wala pong radiotherapy, the risk of local regional recurrence is as high as like 25 or 30%, but reduces it to as low as 9% na lang po. So the procedure po recommended by the clinical practice guidelines is hypofractionation po. So that achieves equivalent rates of local control, overall survival, and cosmesis. Much less siya sa acute toxicity and less fatigue for the patient, then mas nakakatipid po siya in the long run, especially in government hospitals po. Tapos it helps improve access to the patient's therapy. So radiation schedule can also be made more convenient to the patients, and limitations of hypofractionation include parang sa physician's barrier kasi hindi po lahat ng physicians ay as trusting of the evidence of hypofractionation. Of course, there's always the policy associated barriers po sa country natin. And that's all po for the management, for the prevention and health promotion.
Okay, so for the prevention and health promotion, next slide, please. Okay, so at first we need to risk classify our patient before we are able to advise our patient about the screening or prevention methods of breast cancer. So according to American Cancer Society, they defined average risk as having no personal or family history of breast cancer. They're negative for BRCA and BRCA2 gene mutation, and no chest radiation therapy or exposure to their chest from at a younger age, less than 30 years old. And then for high-risk patient, these are the patient who has a first-degree relative of history of breast cancer, positive for BRCA and BRCA1 and 2 gene mutation. They are positive exposure for chest radiation between 10 to 30-year-old, and they also from these rare syndromes such as Leishman syndrome, Cowden, and benign really Ruvalcaba syndrome. So uh, that's for the risk classification. Next slide, please. So for the primary prevention of our patient, usually this is aimed to eliminate cause leading to disease occurrences. That's why we promote for a healthy lifestyle, healthy diet. This includes moderate physical activity of at least 150 minutes per week, avoiding alcohol, and maintaining normal body weight. So these primary prevention methods, diet and exercises are certainly recommended approaches to healthy living. However, these primary prevention method as none has been proven to specifically decrease a woman's risk of breast cancer. But in the researches of last 2017 by the World Cancer Research Fund or American Institute for Cancer Research, strongly recommend this method of primary prevention. Next slide, please. For the secondary prevention, we have different screening methods. Of course, number one is mammography. And then the American Cancer Society recommends of annual screening starting at 45-year-old for average risk women, and then biennial screening of for age 50 and older. And then for that's for average risk women, but it's different case for high risk women. High risk women that have BRCA gene mutation or family history of breast cancer, they usually start at 30 years old already. We have different screening methods also, such as ultrasonography and MRI or positron emission tomography. For the ultrasonography, this only complements other diagnostic exams for guiding a biopsy, and usually low yield in specificity and sensitivity. That's why it's not really recommended. For the MRI, it's also for complementation only, and then complements mammography for precise imaging soft tissues. So MRI is really recommended for high-risk women of breast cancer in certain factors. That typically starts at age 30 already. These newer technologies such as MRI or PET, sorry, it's not included in this slide, has been shown to be superior to mammography in their sensitivity. However, compared to specificity, it's in moderate. That's why it's really not recommended for average risk women. We have here clinical breast examination and breast awareness. Um, uh, Unfortunately, clinical breast examination and breast awareness for screening of breast cancer is not really recommended for average risk women at any age, but still can be offered to high risk women who has a high history of breast cancer and BRCA gene mutation. But still, a patient must know how their breasts normally look and how does it normally feel, so that they can have a prior feeling of their or look of their normal breast before breast cancer arises. So we have also BRCA mutation testing. This is indicated for high risk women. Next one. Next slide, please. We have here another form of prevention, the tertiary prevention. We have chemo prevention, prophylactic mastectomy, risk-reducing salpingo or oophorectomy. Treatment modalities. This includes the selective estrogen modulators such as tamoxifen and raloxifene, and aromatase inhibitor. In general, aromatase inhibitor is much recommended than SERM because it's much effective in reducing the recurrence of contralateral breast cancer or breast cancer in patients who had the breast cancer already. And then but however, the risk in selective in this term is they increase thromboembolic events and endometrial cancer due to their effects on the uterus and the liver. And then the aromatase inhibitor is the most severe and life-threatening risk associated with aromatase inhibitor is the development of osteoporosis, and sometimes patient cannot really tolerate aromatase inhibitor, and they um, complain of musculoskeletal symptoms such as osteoarthritis and arthralgias, and that's why aromatase inhibitor. That's why SERM is usually given to patients over aromatase inhibitor. Then the prophylactic mastectomy and salpingo-oophorectomy is usually encouraged, no, not encouraged, is usually considered to our patients who are at high risk, usually the patient who has BRCA gene mutation, BRCA1, 2, and then who has a first degree relative of uh, breast cancer. But the prophylactic mastectomy is only able to reduce the incidence of and mortality of breast cancer for up to greater than 95%. That's a really good news. But we should always note that the anatomy of the breast is not really capsulated, and that normal breast tissues are can still be left in the chest area after prophylactic mastectomy, and that breast cancer can still arise in those left tissues. So for the we should also consider mental health assessment of our patient. As we know, cancer is really difficult for a patient to fight for. We should always consider other protective factors such as family support to assess their coping mechanisms for the illness, and give support, able to assess their support group also. And then other form of protection also for our patient is the immunization. We should evaluate the current immunization of our patient, such as COVID-19, the pneumonia, flu, MMR, varicella, and vaccines. MMR vaccines that are recommended for adult patients. So next slide. So given this now that we know the prevention methods and the screening of our patient, we're going now to give a brief advice to our patient. So, Tagalog. So, magandang umaga. So, kayo po ay nagkaroon na po ng primary breast cancer, na kayo po ay inoperahan na ng tinatawag na modified radical mastectomy. So maganda at mainam po na gawin po ang mga prevention methods na ito para kayo po ay mananatiling healthy or malakas sa inyong cancer journey. So ito po magagawin po ninyo, like kakain po kayo ng mga sustansya at balanseng pagkain. Maaari nyo din po ibatay sa pinggang Pinoy kung saan mas marami ang gulay at mas onte ang karne at less salt and less fat po. Yan. Tapos mag-exercise po kayo ng at least 150 minutes or 30 minutes kada minuto. 30 minutes kada araw or 150 minutes kada linggo po. Tapos wag po kayong uminom ng alak. Pati rin po yung paninigarilyo, tapos yung second-hand smoke po ng anak at asawa niyo kung maaari po ay pwedeng maiwasan. Tapos magsuot parati ng mask at maghugas ng kamay at mag-alcohol din para maiwasan ang infection, lalo't kagagaling lang po kayo ng operasyon. Kung maaari po magpabakuna po kayo ng mga COVID-19 booster, pneumonia or flu vaccine, MMR at varicella na ito, kasi ito po ay recommended sa adult patients po. And then kayo po ay since natapos na po ang inyong operation, kayo po ay maaring bigyan ng gamot na tinatawag na selective estrogen or receptor modulator, o ito yung mga gamot na tinatawag na tamoxifen at raloxifene, kung saan pinapababa nito ang insidente ng breast cancer sa malusog na kababaihan. Kayo po ay ER positive nung tinest po kayo, kaya mas maganda po bigyan kayo ng ito ay nakakabuti po na endocrine ito ay nakakabuti sa ER positive cancer. Pwede din po kayong mabigyan ng aromatase inhibitor kasi mas effective po ito sa tamoxifen or at raloxifene na nakapagpababa po ng insidente ng contralateral breast cancer sa mga menopause para sa adjuvant treatment ng invasive cancer. So, ngayon na bago kayong operation, sinabi kanina na magkaroon kayo ng pamamaga ng kamay dahil natanggal po yung mga lymph nodes dito sa may kilikili. Tapos at risk po kayo sa infection dahil may sugat po yung katawan ninyo. Kaya kailangan pong iprotektahan nyo po palagi yung sugat sa may operation. Tapos palagi nyo pong itaas yung kamay nyo para hindi po mamaga yung kamay ninyo. Maraming salamat po. That's it for my part, sir.
Ay, sorry, hindi po naglalag ata po yung slides ko, but these are references for our presentation.
Okay, are you done?
Yes, sir.
Everybody is presented? Everybody?
Yes, sir.
So thank you for that extensive presentation with all those data. You have a lot of data information that you presented. Okay. Now let's try to simplify it in such a way that you will apply it to your practice in the future. Okay. So all of these things all of this information that you have read and also presented, it might be useful for your board exam, okay? But in terms of sustaining this knowledge, it might not be easy, right? Especially when you are not going into a specialty of the breast, okay? So let's try to discuss this from the perspective of a basic physician, something that you can remember, okay? So that when you after your board exam, when you see a patient, you know how to manage it, okay? The most basic way, okay? So we will try to use the patient management process, okay? We will try to use the framework in our discussion, but along the way, I'm going to give comments as I have perceived in your presentation. No? Okay. So you have a patient who is a 50-year-old female presenting with the right breast mass. Okay. You mentioned breast mass. Usually when you ask the patient, what's your problem, right? So patient will say, may bukol kami, may bukol ako. Okay? Tama? So pag may bukol siya, you ask them, simple questions lang, nasaan mo nakapa? Okay? So she will say, in this particular patient, probably she will say it's on the right side. It's very clear. Na? Okay? So that's why in your data recording, you put there chief complaint, breast mass, and then right side. Okay, put the location already, di ba? Kasi, and then when you put the notation breast chief complaint or chief concern, main concern is a breast mass, you put the open close parentheses in quotation marks, no? In quotation marks, put the mass in quotation marks because this is just the starting point of your interview, okay? So she might be referring to a mass, breast mass, which might not be a breast mass after all, okay? She might be referring to a prominent rib, especially on the second rib, okay? Or she might be referring to a prominent xiphoid process, okay? So it's incumbent upon you as a physician to verify it, but you ask first where she felt the so-called mass, okay? so that it will facilitate your palpation, your examination. Okay. If you keep on palpating the breast and then you don't see any mass, you just tell her, ay, wala namang bukol ah. No? Okay. Then she'll tell you, andito ho, nasa xiphoid process. Okay. Okay. Or the prominent rib, or a lot of times they have different interpretation of the breast mass, right? Okay. So, i-verify lang ninyo after asking her where she palpated the mass. Okay. Okay, sabihin natin, she palpated the mass on the right side, on the right lower inner quadrant, doon. Now, in this particular patient, doon ang lesion niya, di ba? Lower inner quadrant, no? Okay. Then you palpate it, no? Okay. Now, if you were able to palpate, you don't have to go through the routine interview mahaba-haba, no? Okay. In the clinics, you just say, what's your chief complaint, what's your concern, and then you add one more questions, where she palpated it, and then when did you first note it? Okay. Okay. So wag niyo tatanungin na when did you discover it? Now, when did it start? Don't ask that question. Okay. Okay. So she can give an answer, but it will not be reliable. No? Okay. So when was it first noted, or when did you discover it? No? Okay, just accept it as is. No? So in this particular case, she discovered it in April 2021. Tama? Tama? Okay. So it doesn't mean that it started in April 21, that mass. Okay. Maaga pa yan. No? Okay. And considering that mass has ruptured already, no? Okay, most likely, mas maaga pa yan. No? Okay, hindi lang niya napapansin. No? Okay. And then, you ask also another question, were you treated before by other doctors? No? Okay. So yung sinasabi niyong ancillary history, no? You can trim it down to just these 4 questions, no? 4 or 5 questions. Were you treated before? No? So, when she answered that she has been treated before, yun na, yung lumalabas yung mga data that you presented. Diba? She was treated by another doctor who gave her antibiotics, no? And then she went to PGH, no, for treatment, right? Okay, so you got all these answers, and then you can utilize all the data that you got from the answers to this question to your diagnosis. No? You process it. No? And then the 4th question that you can ask is along the part of your ancillary history, do you have other diseases? No? Okay. Just to check whether it will compound your management of this particular problem, which is the breast mass. Okay. So basic 4 questions lang, no? And then you can ask more questions as you go along. So examine na ninyo, no? Okay, examine the patient right away, no? Okay, so you can ask these questions probably 1 to 2 minutes, and then examine the patient already. And then while you examine the patient, you can ask more questions based on what you saw in this particular patient. Okay, so let's go back. Doon sa history na yon. Kasi yung sa inyo ngayon, you get all the kompleto na yung data ninyo, no? So assuming that you were the one who saw this patient for the first time in April 2021, okay? So ano yung presentation ng April 21 where she was given antibiotics?
Sugat po yung parang pinakauna po niyang sinabi na complaint.
Okay, sugat, no? Sugat lang, no? So when you examine that sugat, you have to examine that sugat, di ba? Okay. So check whether there is a mass or not. No? Okay. So in the examination of the breast, importante whether there is a mass or not. Yan ang pinaka-basic. No? Okay. So there was no mention dun sa history ninyo, no? Kung may mass na kapa. No? Ang nakalagay doon, scar lang, di ba? May scar-like something. No? So that's probably the area where the rupture has occurred. No? Okay. At sinabi niya may nana. Tama? May nana. Okay. Okay. So yung first physician who saw her or when you are the one who will be seeing this patient for the first time. Okay? So if there is a mass there, okay, kasi scenario could be there's no mass, may sugat lang siya, no? May nana. Okay? So pwedeng nasugatan lang siya, di ba? Okay. Or there's a mass there, no? Na may nana pumatok, no? So if there is a mass there, assuming that there is a mass there, your line of thinking will be it could be a mass that could be a breast cancer that has ruptured, no? Or it could be an abscess that has ruptured. Okay, breast abscess that is ruptured. Those are your differentials. Okay, so then you go deeper into in examining this patient. Kung talagang may mass o walang mass, no? Okay. Now, kung di ka sigurado, if you are quite sure that it's an abscess that is ruptured, then you don't have to do any laboratory tests anymore. Okay, so you just treat the patient with antibiotics or cleaning of the wound. No? But if you suspect that there might be a mass, no, medyo mahirap lang kapain, no, okay, then you go for a paraclinical diagnostic procedure, okay? So the indications for paraclinical diagnostic procedure is one, you're not quite certain of your clinical diagnosis, okay? That's a basic indication. If you're quite certain, then you don't need any paraclinical diagnostic procedure. Na? Okay. So, itong pasyente nito, April, binigay siyang antibiotics. So, hindi siya gumaling. No? Sabihin natin, same situation as you did, probably nag-try out kayo yung antibiotics thinking it's an infection. No? Okay. Then, kailan siya bumalik? She came back to breast PGH na, di ba?
March 2022 po.
Okay. So,
A year after.
a year after, meron kayong data on the, may mass na nakapa ng BCC? May mass na ba? Wala tayong data?
O, ang na-mention niya lang po, yun yung time na pinag-ultrasound and mammogram po siya.
Okay. So assuming that there's already a mass, no? Okay. And then there's still a discharge coming out. May discharge pa siya, di ba? Tama? So you're now thinking of possible breast cancer, no? Okay. So, okay, let me now comment yung basis niyo for your diagnosis, clinical diagnosis is based on pattern recognition and prevalence. Okay? So yan ang tinuturo ko, no? You have heard about the so-called hypothetical-deductive reasoning process, di ba? Okay. So, mahirap intindihan yon, di ba? Okay. For me, it's easy to understand the pattern recognition, meaning what are the symptoms that will represent a pattern for a particular disease. Okay. So, in this particular case, you have a breast mass, medyo pumotok, may break in the skin. Okay. So you're now trying to process it. What is it? No? Okay. Is it an abscess? Is it a breast CA that is ruptured? Okay. Are there special types of breast CA that can present with that one? No? Okay. Inflammatory breast cancer could be another small type of cancer. Okay. So you look for the pattern of the symptoms. Okay. So don't use the risk factors muna. Don't use the risk factors. Ancillary lang yon, no? Okay, look for the pattern. So you start with the breast mass. Merong breast mass, no? Okay. You ask the question, is it inflammatory or not inflammatory? Okay. So what are the signs of inflammation? Signs of inflammation will be pus. May pus yan, di ba? May pus, kaya okay? And then, erythema. Okay, ano pa? Warm. Ano pa? Tenderness, pain, tenderness. Okay, ano pa? Meron pa? Fever. Okay, so those are the hallmarks of inflammation, infection. Tama? Okay. So titingnan mo lang kung may pus. Kung walang pus, you rely on the erythema. Okay? Minsan wala pang pus yung bukol na yon, no? So erythema is a very reliable sign. And then kung walang erythema, hindi masyadong reliable, but if it exquisitely tender, no, baka talagang may infection doon, may abscess, no? Okay? So that's what I meant by the pattern for an infectious or inflammatory mass. Okay? If you have one of those signs, cardinal signs of infection, you say most likely this is a breast abscess or inflammatory mass. Okay? Then you quantitate it, no? Kasi kung matagal na, kasi you expect it, yung mga abscess niyan, one month, tapos na yan, or 2 months, no? Okay? Pero ito, nagstay yan for 1 year, di ba? 1 year, no? Tapos baka, assuming that you palpated the mass, no? Okay? Then you have to have a secondary impression of cancer, di ba? Aside from the inflammatory mass, now which could be an old abscess, which could be a TB. TB can also behave like that. Long history, no? Okay, TB of the breast. Okay, and then your secondary diagnosis, it's a breast cancer which is ruptured, no? Which is already ruptured. Okay. Then after that, kung na-eliminate mo yung inflammatory mass based on the symptoms, sabihin natin you're now entertaining a non-inflammatory mass, then you try to decide whether this is malignant or non-malignant. No? Okay. So you look for pattern of symptoms for malignancy. Okay. Okay. So in this particular patient, wala tayong data, no? Because you were not the one who saw this patient. No? Okay. So if there is a mass that is fixed, no, that is fixed to the underlying chest, and then there's skin, may skin ulceration. Were you able to see this patient before the operation? But this one had chemo already, no? So medyo na,
Yes.
distort na, no? Okay. So if you see this patient na may may ulceration, di gumagaling, so you entertain breast cancer na, no? Okay. Kasi, okay, how I utilize the prevalence? Ito yung example, no? Breast cancer versus TB. Pwedeng TB rin yan, di ba? Theoretically, okay? TB can present with ulceration, with a granuloma, okay? But which one is more common nowadays? No? Breast cancer pa rin, di ba? So breast cancer is more common than TB, then you choose TB as, you choose breast cancer as your primary diagnosis, okay? You get it? So don't use the risk factor. Kasi yung ginagamit yung risk factors like yung age, di ba? Yung age is not very reliable, no? Kahit na yung sinasabi ninyo, the prevalent age incidence is 49. You mentioned about 49 or 39, 49 to 50, something like that. Sinong nag-present now?
Yes
Janine?
po.
Okay.
Yes po.
But age can occur at any time. Breast cancer can occur at any time. No? Okay. Yung mga rare one, it can occur at age 30. Minsan 28. No? Okay. So what's more important is on the pattern mo na. You rely on the pattern. Pattern means what are the signs of malignancy, signs of benignity, no? And then signs of inflammation. Doon kayo mag-rely. No? Okay. Yung sex, gano'n, sex. Huwag mo nang isama yung sex. Usually, babae naman talaga yan, di ba? Okay. And then you talk about yung family history. Example of unreliable in family history in most of the time that you have to rely on if your PE shows that, okay, example, just to drive home the point, exaggerate ko lang example ko, ha? So you have a 30-year-old female presenting with a breast mass, no? But she has a family history of breast cancer, okay? But the breast mass on PE based on, you're looking for the characteristics of the mass based on the PE. The mass is movable, the mass is well-defined, the mass is non-tender, the mass is sabihin natin, solid but well-defined, no? Okay. Your primary impression should be a benign one, no? Rather, don't be influenced by the family history first. You can put their secondary as breast cancer, but your primary impression should be a benign breast tumor, no? It could be a fibroadenoma, okay? Okay. Not because she has a family history, then you make your diagnosis as breast cancer, no? As the number one, no? Okay. Mauuna muna yung put priority on the physical findings, which constitute the pattern, okay? Okay. Now, if you have a 25 years old presenting with a lump, okay, sandali, ha? Presenting with a lump, but it's fixed, there are lymph nodes, now, kahit na wala siyang family history, you still consider breast cancer based on the pattern. Okay, binaliktad ko lang yon, ha? May family history without family history. Okay? So my advice is focus, put priority in when you process your clinical diagnosis on the signs and symptoms that will represent a pattern of a particular disease. Na, yun muna. If there are several entities that will present the same pattern, you invoke the prevalence, kung anong mas common. Okay, to be able to choose which one should be your primary, which one will be your secondary. Secondary is the second most probable. The primary is the one which is most probable. Okay? Kasi when you do your diagnostic test, para clinical diagnostic test, you focus first on the primary. You don't focus on both. Diba? Kung kumuha ka ng test na considering primary and secondary and other differentials, you're doing shotgun diagnostic workup. Na? Okay? So, piliin nyo muna yung primary, and then doon kayo gumawa ng paraclinical diagnostic procedure kasi you just want to firm up your primary diagnosis. Okay? Get it? Okay. Ganun din sa oral contraceptive. We know that a lot of people are taking oral contraceptive, di ba? Okay. So how often do you get breast cancer? No? Okay. And we cannot really pinpoint yung mga for people who take oral contraceptive, hindi man lahat nagkakaroon ng breast cancer. Yung mga failure to breastfeed, di ba? Second-hand smoking, lalo na educational attainment, di ba? Medyo subjective siya, di ba? Okay? So don't use those risks, yung theoretical risk. No? There's another one actually which was not mentioned, palagi na-mention sa libro, yung long history of menstruation, di ba? Mahaba, na? Okay. So hindi siya it's not applicable in the diagnostic process. No? Okay. Mga probably for research information lang yon, no? Pero hindi nagagamit yon, no? Ang nagagamit yung pattern recognition and then prevalence, no? Okay. So what's the definition? Let's go back. What's our definition for pattern recognition, Janine?
Sorry, I don't know the like the definition po. Pero isn't it yung parang
nabasa mo yung slides ko?
Yes po, but I also parang I'm basing po sa video. Let me pull up
May video rin ako doon, di ba? Patient management process.
Pattern recognition po, realization that the patient's presentation conforms to a previously learned picture or pattern of disease.
Okay. I hope it's clear to everybody. No? And usually, you look for the signs, then the symptoms. Yung symptoms is gotten from the history. Signs are gotten from your PE, physical exam. Which one is more reliable?
Physical exam po.
Which one is more physical exam? Okay? Physical exam is more reliable kasi yan ang kinukuha mo. But doesn't mean tama ka palagi, no? Because there are some situations na hindi ka rin sure because of the iba-iba yung katawan ng pasyente, iba-iba yung presentation ng diseases, no? Okay? But make sure that you are accurate. If you're not accurate, admit it, baka hindi mo kaya ng gano'n. That's the time you go to the paraclinical, no? Okay? Okay, acceptable yung limitation natin, no? Okay? So, but rely first on the PE. If you have PE, kung wala kang PE na makikita, then you rely on the sign, on the symptoms. Okay? So when you come out with a clinical diagnosis, meron kanina, I told you to quantitate the degree of certainty, di ba? Degree of certainty. This is not being taught in the textbook. Okay? But in practice, we do that. You're now third year, fourth year. Third year clerk. You're third year. So
Third
you're
year.
exposed to the clinics already. You're exposed to the clinic. So I suppose you have several occasions when you palpate something, when you do PE, you can say, oh, I'm quite sure of this one. I'm not sure of this one. Tama? Okay? Ganon din sa lahat ng doktor. Okay? Kahit na expert na sila. Okay? Okay, remember that. Ha? Kahit na expert na sila, there are certain times in which we can say, I'm not quite sure. Okay? I'm quite sure. With my experience, probably with more experience, initially probably your first encounter with a rare, not uncommon, or you have not seen a patient like this before, medyo uncertain ka. But with more experience, no, nagiging quite certain ka na. Okay? Okay, so yung how to quantitate the degree of certainty, we have to quantitate it because we have to decide yung next step whether to do paraclinical. Okay, to be able to decide whether to do paraclinical, we have to answer the question, how certain are you with the primary diagnosis? Okay, as a rule, as I said, as a rule, if you are quite certain, you don't need your paraclinical. Logical. If you're not quite sure, at any kahit na level ninyo, if you're quite not certain because you're not expert yet, nobody can fault you. Okay? As physician, nobody can fault you. Basta you justify it. I'm not quite sure of my findings. That's why I need a paraclinical. Okay? Get it? Okay. So,
Yes.
if you make a diagnosis that is based on signs, then nagja-jibe yung symptoms, and then nagja-jibe yung prevalence, okay, you can say that you are quite sure. Okay. Now, if you, as these are rules, now principles. If you make a diagnosis based on symptoms only, or kahit na may prevalence, no, you're not quite sure. Okay? Kasi symptoms are not very reliable all the time, no? So you can say that you're not quite sure. Yung sign ang pinakamabigat doon. Okay? All the more if you just base it on prevalence. No? Sabihin natin, your relative asked you over the phone, no? They alam nila magiging doktor ka na, no? Baka may alam ka na, no? Sabihin natin, ito yung kamag-anak mo may bukol sa breast. No? No? Sabihin mo, 30 years old, yung kamag-anak mo may breast mass. So, you don't have a chance to examine the patient. You don't have a chance to ask for more data. No? Okay? But you base your diagnosis on the prevalence. Ano yung pinaka-common breast mass? Kahit na anywhere, Filipino or international. Benign, malignant.
Benign.
Benign, di ba? You will say it's benign because it's based on prevalence. So, pag may sinabi mong most likely it's benign, your degree of certainty is not very certain. Di ba? Kasi you just base it on prevalence. You still need to examine this patient to get the signs, di ba? Okay? If you are able to examine this patient to get the signs, then that's time you can decide whether you are not certain or quite certain. No? Okay? Okay. Kaya yung kahit na may mga laboratory test na binibigay sa iyo, no? don't forget to examine this patient to get the sign before you commit to any diagnosis, no? Okay. Okay. Nakikita niyo yung mga laboratory tests, mga ultrasound, they will always, there's a caveat, there's a statement there. Please correlate clinically. Please correlate, na? Okay? So, kasi pwede magkamali yung radiologist, na? Okay? Okay? So, now, what is the cutoff that I use? 90% is the cutoff that I use, na? Most of the tests, if you are that are acceptable are usually 90%. Pag 90% valid or accurate, no, then you call it quite certain. But you can go higher than 90% to 99%. That's the most. Kung gusto mo 99.9, don't commit to 100%. Okay? Kasi mapapaso kayo. Okay? Don't commit to 100%. There's no such thing as 100% in this world. Okay? Okay. Now, below 90%, you can categorize it not quite sure. Okay? Okay. So, in this particular patient, sabihin natin may breast mass, ulceration, may rupture that was May 2022. So, based on the limited data, your primary diagnosis is breast cancer. You're thinking of breast cancer or TB, okay? TB, okay? And then, so you need a paraclinical diagnostic workup, na? Okay? So okay? Before you decide on the type of workups that you want to do, aside from let's say more than 90% yung ano mo. Let's put it less than 90 muna, ha? Kasi we don't have enough data. Less than 90, let's say, pero that cancer is your primary, secondary is TB, no? Okay. Sabihin natin 80% na cancer, 20% yung TB. So it should add up to 100 kasi dalawa lang diagnosis natin, di ba? Okay. So for you to decide whether you need a paraclinical, you look at your degree of certainty. So 80% kulang sa 90, so you need a paraclinical. Na? Okay? Then, now the other thing that will make you, the other process that you use, whether to go for paraclinical diagnostic procedure, is that you look at the treatment plan for both. No? So it doesn't mean that all the time that you're not quite certain that you have to forego your paraclinical diagnostic procedure. Because if the treatment for number 1 and number 2 are the same, no, then you don't need to do a diagnostic procedure anymore. Example, in this particular patient, if it's a TB or let's say whether it's TB or fungal infection, no, mahirap bigyan example ng cancer. Okay, sabihin natin cancer. Sabihin natin it's something benign, but example lang ito just to illustrate, ha. Because the treatment might be the same, we just remove the entire tumor, the mass, no, then you don't need to have a pre-op diagnostic procedure. Because after matanggal naman yan, you will have it biopsied anyway. Na? Okay? So you can forego with your pre-op mga studies. Na? Okay? Now, in the same way, dun sa ano naman, if you're quite sure, 90%, you can still justify your doing a diagnostic test if you need to increase the degree of certainty to a higher level. Let's say you want to put it at 90%, 95% or even 98%. Okay. So examples of justification, because this patient will, if it's CA, she has to undergo chemotherapy. And as we know, chemotherapy is not an easy treatment. Or if she has to undergo a mutilating operation, then you have to increase from 90, you have to increase it to 98%. So you need diagnostic workup. Okay. So those are exceptions to the principle that if you're quite sure, you don't need diagnostic tests. If you're not sure, you do diagnostic tests. Okay. So you look at the treatment plan for both, you compare. Kung pareho lang, as a rule, you don't need diagnostic test. Then if you have justifications, you want to increase it further, no, you can do diagnostic tests. Okay? Is this clear? So, tapos na tayo sa
Yes,
clinical.
sir.
Any questions? Okay. So, tapos na tayo sa clinical diagnostic process, ha? Clear na, ha? Okay. Don't use the risk factors. Go to the pattern na. Okay. Bakit breast cyst? Bakit breast cyst ang ano ninyo?
Sir, it's primarily due to the mass daw po na nasabi and also mostly sa prevalence po lang.
Okay.
Talaga
What's your concept of breast cyst? Saan mo nakuha yung breast cyst na term na yan?
Yung breast cyst po, it falls under one of the categories sa fibrocystic breast changes po, which is yung non-proliferative.
Non-proliferative?
Ay,
Saan mo nakuha? Saan mo nakuha yung ano? What's your reference?
ayun po, it falls under the non-proliferative lesion under benign breast diseases po.
Okay. Yeah, okay. Okay, I don't know kung ano sinasabi doon sa libro, ha? Let me give you some input, okay? The word cyst per se implies it's benign, right? Most of the time, 99% of the time, lalo na sa breast, no? Okay? In other organs, baka hindi ganun kataas, no? Let's say sa ovarian, no? Cyst, no? Baka mas mababa ng konti, no? Okay. Now, when you say breast cyst, it contains fluid, right? Okay. And then there are several types of cysts. You can have the microcyst and the macrocyst. The macrocysts are those which are palpable. No? Malaki, di ba? Palpable. And then yung microcyst, usually mga less than 1 centimeter yon, not palpable. Okay? So when you talk about breast cyst, you have to qualify, is it part of yung microcyst that is part of fibrocystic changes. Okay? Fibrocystic changes versus yung macrocyst, yung kapang-kapa. Na? Okay? So which one are you referring to when you talk about breast cyst here? Yung hindi nakakapa. Pero nakakapa ito, di ba? Okay? Saka kung macrocyst siya, usually you can detect it by pressing on the mass. If it's depressible, okay, it's compressible, which signify it contains fluid, then yun na yun. You have macrocyst as your diagnosis. No? Okay? So, but in this particular patient, it presented as I suppose it's a solid mass. No? Okay. Nagkakagulo lang tayo kasi we don't know kung talagang palpable or not. Kasi yung sa history niya magulo, di ba? Yung sinasabi ng pasyente nawala na, di ba? Then, in other areas of your presentation, may 2 to 3 centimeter mass pa. Ano? Okay? So the only way in which we can resolve this, do you have the ultrasound result? You have the ultrasound result before the chemo?
No, sir.
Wala. Okay, yan magulo. Wala tayong ano. After, wala na. Wala. So you don't have any records of the ultrasound? Wala. Okay. And I won't ask the question anymore whether you reviewed the chart. Most likely you were not able to review the chart. No, importante yung chart, no? Kung anong data nakalagay doon by the resident in BCC. No? First time that they saw the patient went to BCC, dapat may magandang records na yun. No? Okay, wala. You were not able to see the records. No? Okay. So in this particular case, as I said earlier, it's a toss-up between an abscess at the very start, pero tsaka CA, no? But tumagal ng 1 year, no, andyan pa rin, no, most likely CA siya. If not CA, TB, di ba? So you don't consider yung fibrocystic, no? Fibrocystic changes, no? Okay? Or kung macrocyst, madali namang ma-detect, no? Okay? So I hope I have clarified the phrase breast cyst inyo, ha? Okay? So, moving forward, na core needle siya. Sandali, ha? Sandali. Okay, let's reset natin, ha? Starting point natin ngayon is tanggalin muna natin yung mga data that you got from the resident, na? Okay. So your pre-op, your diagnosis, clinical diagnosis is breast CA versus TB. Okay? Number 2, okay? So you need to do a paraclinical diagnostic procedure because if it's CA, you might be if you stage this clinically, kahit na wala pa yung biopsy, you already stage it at T4, di ba? T4. Now, we don't have data kung may palpable nodes, di ba? Meron ba at the time of examination? If there is palpable nodes, malaking-malaki, that could be N1. No? Okay? So kahit na 90% sure na tayo, we still need to do a paraclinical diagnostic procedure because the patient will have to undergo chemotherapy kasi malaki yung bukol, no? I mean, T4 na, no? And eventually, she may have to undergo surgery, which is mutilating, which could be mutilating, no? Okay? So you have decided that you need a paraclinical diagnostic procedure, okay? So the next thing to do is selection. So you have to select, okay? That's the next step. So yung table na present niyo, tama yun, ha? First column is the options. Second column is the B, benefit, risk, cost, availability, okay? So what I just noticed your comment lang, kasi when you do this paraclinical diagnostic procedure, huwag niyo isasama mo na yung extent of the disease. So you include only the diagnostic procedures that will be directed towards your getting the primary diagnosis, whether this is TB or CA. Yan muna. Yan ang priority niyo. So you don't include all the CT scan to check the extent of the disease. Okay. Wag niyo isasabay muna, no? Okay, later on na yan. Pag na-establish na breast CA, then that's time you can, if you want to know the extent of the disease, then you can do the bone scan, the CT scan, etc. Okay? Okay? So, you're trying to distinguish, your primary is breast CA, number 2 is TB. So what will be your options? Okay. Wag niyo isipin ko anong ginawa ng PGH BCC, ha? Huwag niyo isipin mo na. Theoretical discussions. So you need a paraclinical. What are the options?
Would it be po mammogram?
Okay. Mammogram. Sige, list down the option. Mammogram.
Breast ultrasound po.
Ultrasound. Ano pa?
Those two po muna to locate the lesion and to classify it po. And then a core needle biopsy to determine whether or not it's malignant po.
Or biopsy.
Yes.
Let's slap them together. But there are several types, no? Di ba? So what you mentioned is just core. Kasi na-influence kayo. Di ba? Okay. What are the different types of biopsy?
Fine
Core
needle aspiration.
Fine, core, ano pa?
Aspiration. Excision po.
Excision, ano pa?
Punch.
Punch. Okay? So, several yan. Palaging maraming options yan, ha? Just remember that, ha? Maraming options, no? So you have biopsy muna. Okay, let's put lump the different types of biopsy under one. Biopsy, let's compare it to ultrasound and mammo. These are the basic, di ba? Okay. So ang starting point natin, there's a break in the skin, meron nag-uus ng fluid, no? And then there's a induration sa below that wound, now which could be a mass, no? Okay. So anong benefit? When you say benefit, kasi kanina 90% tayo, ha? So which one among the three will increase your certainty the highest, to the highest level, let's say up to 99% among the three? Mammo, ultrasound, and biopsy.
Biopsy po.
Biopsy, why?
Aside from the fact po na you get histological samples, so you're able to tell na po kaagad if it's an infection, if we want, or a malignancy, if we want to determine po among our primary and secondary clinical diagnosis po. So, and then we can also get other information aside from if it's either an infection or a lesion po on what type of malignancy it can be. So,
Yeah, yun ang primary benefit yan. You have a direct way of doing things already compared to indirect ways of mammo and ultrasound. Okay? Mammo and ultrasound is based on imaging lang of the mass, di ba? Okay, so it's an indirect way, di ba? Whereas biopsy, you get a sample. Okay? So that's the most direct way. Yeah, may advantage na siya, no? Okay? And you know that it can distinguish between a CA and a inflammatory, no? Okay? So that will be the best among the three, no? Then how about comparing the ultrasound and mammo? Anong advantage ng ultrasound? It can show you the structure, whether it's cystic or solid, di ba? Okay. Whether you have an ill-defined mass, there's really a mass or not, no? Okay. Okay. Ano pa? There's a mass, and then the border of the mass, the characteristics of the mass. Now, if there's a mass, whether it could signify a cancer or not, pwede, no? Okay. Mammo, pwede rin, no? It can show you some density. It can also show you yung microcalcification of breast cancer. Okay, kung meron. Okay. So, you have to decide which one is the best. Pero in practice nowadays, palaging sinasama nila, no? Okay, combination, mammo and ultrasound, no? Which not everybody will agree, no? Okay. Kasi when you do a mammo, okay, this will be my input to you for practical, ano. So when you do a mammo alone, usually ang practice ng mga radiologists, they don't like to commit. No? They will say, have you heard about the BI-RADS thing? Okay. They will always say it's BI-RADS 0. They will ask you, I need an ultrasound. No? Okay. That's the usual practice in the Philippines and abroad. Okay. That's why patients ended up with so many tests na pwede naman isa lang. No? Okay. Added cost lang yon. No? Magkano yung ultrasound mo? 1,300. Mammo, Joy B, magkano yung mammo? 3,000?
6.15.
Mura yon. Okay. Okay. So usually mga 2,000 to 3,000 yung mammo. Mas mahal yung mammo. Okay. So if you add the two together, then you will have mga 4,000, 5,000. No? Whereas if you can get the information with ultrasound, pwede na, di ba? 1,500, pwede na. You can get, pag kailangan na lang, then that's time you do them. And then that's I'm telling you, that's the usual practice in the Philippines. Now they want to do both. If you just do one, they will say, I need a further test, no? Ultrasound. But strictly speaking, you can already make an interpretation of the mammographic findings, whether there are microcalcifications or not. And then the border, whether there's speculations of the border of the mass. No? Okay? Pero the usual practice no, here in the Philippines, they put the BIRAD 0, no? To the point that a lot of doctors are being forced to do additional ultrasound. No? Okay? So for me, pwede na ang ultrasound muna. Okay? If I need more tests, then I can do a mammo. Pero if I get the information already with ultrasound, tama na yun. No? Okay? Okay. So sabihin natin, it's now a choice between ultrasound and biopsy. Mas maganda pa rin biopsy. Tama? Then you tell the patient, now, we need to do a biopsy. Now, if the patient, so I don't have to discuss the risk already. Biopsy, you have pain. Ultrasound, no pain. Di ba? Okay. And then cost, you know the cost, no? Okay. And then available, they're both available. Okay. So you tell the patient, give the patient all this data. Okay. So as much as possible, educate the patient on the data and then try to help them decide. Pero kung ayaw nila talagang yung biopsy muna, then give in, okay, we can do the ultrasound first to get more information, okay? But you have to talk to the patient, huh? Okay. Now let's go to the different types of biopsy. Fine needle, core needle, and this one is an open wound, no? So Jan, you mentioned punch, diba? Okay, punch biopsy. So pag may open wound, you can do a punch biopsy. Kung close wound, you have to do you have to cut through the skin to get either a piece of tissue, which is a section, or excision, the entire mass. Okay, so those are the differences. No? Okay, so in this particular case, the best is still that there's an open wound already, you do a punch biopsy. That's the most accurate way, no? Compared to a needle or a core needle, no? But these two, the fine needle and core needle can be done. But if you have a wound already, the simplest would be just to punch the tumor and then submit that for biopsy, no? Okay. So, kumisan, okay. So don't ask me why a core needle biopsy was done, no? There was no mention of fine needle, di ba? Okay, what I'm telling you, you have different options, na just know the pros and cons, no? Okay, so a lot of doctors do not use this process. They just choose which one is the most popular one, okay? So before it used to be fine needle, then fine needle hindi na naging popular, naging core needle, di ba? Kasi maraming fine needle can give you, there was a slide that shows core needle will give you more than 90% yield, right? Sino nag-present nun? Sino nag-present ng slide na yan? In your presentation? Sino? I forgot. Sino?
Sino rin ata po, sir?
You? Austin, ikaw?
Hello, sir.
Sino rin po, sir?
Si Noreen, di ba? You presented the slide. Core needle carries a more than 90% accuracy. Tama? You forgot.
Yes po, sir.
You forgot your
Yes, sir.
presentation. Yung needle by fine needle.
Yes. No, I wasn't able to hear po.
Okay, yung fine needle
Sir?
also carries a more than 90% accuracy rate, no? As long as it's properly done. There's, as I said, there's no such thing as 100%, di ba? Okay. Pero yung core needle, kasi it gets more tissues, greater amount of tissues, no? The usual yield is about 95, more than 95, 97, 98, no? Okay. So yung fine needle, 90%, no? So when you compare the two, you don't say, okay, sabi mo, mas mataas yung core needle ang yield, no? Okay, compared to the fine needle, no? Okay. But you have to consider yung situation. So what probably more hematomas with core needle, no? Ang advantage naman ng core needle, more tissues to be sampled, no? Okay. Pero yung 90% is good enough. Basta any test that is 90% will be good enough, okay? But it might not be as, it's not better or as good as another test which carries a 95, 98%, no? Then that's time you have to consider the cost, no? And other complications, no? Side effects, no? And then also the availability, no? Okay, as you mentioned, some hospitals do not have these facilities for core needle because you have to buy the equipment, no? Yung needle na core needle na malaki, no? You have to buy it, no? Okay. Yung fine needle, you just use an ordinary syringe and the needle, it's readily available, no? Okay. Okay. So lumabas yung core needle. So you choose, let's say the patient, after telling the patients all the options, no, and then you have the ultrasound report that probably shows the may suggestion of a tumor, na cancer. Then when you have an ultrasound that shows possible cancer already, from 90% in your clinical diagnosis, naging 95 na. Sabi natin, 95, example. No? Then you want to increase it further because the patient will have to undergo chemotherapy and also operation. So you do a core needle, di ba? Okay, in this particular patient, a core needle was done. Pero pwedeng punch biopsy, as I said. Pwedeng punch, pwedeng fine needle if you want, no? Okay? So pre-op diagnosis, meron na siyang yung core needle, lumabas invasive ductal carcinoma, no special type, no? So that will be your pre-op diagnosis now, no? So then you stage this patient, no? In preparation for your treatment, no? So the stage here will be stage 4 before the chemo, or stage T4, N1, M0. Okay. So stage 3B. Okay. So you spell out your objective. Your objective should be, you want to resolve the patient's problem. I use the word resolve now just to be neutral, kasi we have different specialties, we have different treatment modalities. When you say you want to remove, that implies that you have to do surgery. Okay, so you just use the generic term resolve now, which can be done by removal, surgery, radiation, okay, burning the cancer, or chemotherapy by killing the cells. No? Okay, para walang bias. No? So as a general statement, you want to resolve the breast cancer in such a way that there will be a high incidence, high rate of remission. Okay, not really cured, basta remission lang, na walang recurrence. No? Okay, that's the basic goal of treatment. No? Okay. So after that, after you spell out the objective, then you spell out the treatment options again. No? Okay. So treatment options will be what? Surgery, chemo, radiotherapy, hormonal therapy. Okay. So assuming that she has ER/PR already, diba? Positive, then HER2 negative. No? So you can use hormonal, diba? Okay. So these are the usual 4 primary treatment modality: surgery, chemotherapy, radiotherapy, and hormonal therapy. Okay. So you now have to decide which one will you use first. Okay. So what is the benefit of using surgery as number 1, compared to chemotherapy, radiotherapy, and hormonal? Now, i-compare ninyo, no, in terms of ano. Okay. So since this is already T4, mahirap tanggalin with a clean margin. So you want to decrease the size of the mass first, no, before you operate. No? So that's the plan. No? So that's why chemotherapy was instituted first. No? So you have to tell the patient the reason for doing the chemotherapy. No? So pag lamit na, then you put in surgery. Okay. After surgery, you may, kasi T4 na ito, to start with, you may add radiotherapy to prevent the high risk of local recurrence. No? Okay. Then after that, for your tertiary prevention, no, we'll be adding a hormonal therapy. Okay, because patients is ER positive. No? Okay. So ganun yun, ha? BRCAV then, i-compare ninyo yung primary treatment, and then you can also compare if you are, anyway, it's very sophisticated na. You can have a combination as one of the options: surgery followed by chemotherapy, or surgery followed by hormonal therapy, or chemotherapy followed by no, different combinations, and then you just compare them in terms of benefit, risk, cost, availability. Okay. Okay. So I have to tell you that different doctors will have different ways of deciding. Okay. What's more important is to get the information. How did they decide on that? Nah? Okay. So if they can present the data in this form, no, first columns the options, and then second columns the benefit, comparing the differential benefits of the different options, and then the risk, and then the cost, availability. That's acceptable. Basta may rational, no? May basis for choosing, no? Okay. Okay. Any questions so far before we go to the last one?
I think none po, sir.
None. Wala. So yung mga test niyo, yung mga chest CT scan, chest X-ray, this will be done after, no, for the extent of the disease, not for the primary diagnosis. So yung surgery dyan, there's such thing as classical radical mastectomy and modified radical mastectomy. Okay, so in this particular case, if in modified radical mastectomy, you preserve the pectoralis muscles below. Okay, in classical, you remove the muscles. No, okay, but if the mass is fixed here to the chest wall, because this is T4, but it has we don't know whether it's complete response or incomplete, because iba-ibang data na present sa atin. Okay. So if the tumor is adherent to the muscle, then a part of the muscle can be removed. Okay. But that does not make it a classical radical mastectomy. It's still a modified, just part of the muscle. Okay. To get a clearance. And then, of course, you talk about breast. You let the patient tell the patient she might want to have breast conservation, but when you have such a stage of the disease, usually, and because of the financial considerations, don't go for the breast reconstruction anymore later on. No? If she is in remission for about 5 years, 10 years, kung aabot pa siya doon sa 5-10 years, then you can start thinking about breast reconstructions. No? Okay. To be practical about it. So the last topic is prevention and health maintenance. No? Okay, when you say prevention, prevention is for this patient who has undergone surgery, okay, treatment. So you want to prevent the recurrence. No? Okay, tama yung sinabi ninyo, in primary prevention, will we go back to the healthy lifestyle, avoid all the risk factors of a breast cancer occurrence. Okay. And then for the secondary prevention, we define secondary prevention as early detection, diba? So in this particular patient, we're talking about early detection of recurrence. Okay, we're not talking about early detection of a primary disease, diba? Okay, so this patient has breast cancer treated. So secondary prevention will be early detection of the recurrence. no? Kung magre-recur, no? Okay. So, you have heard about cancer surveillance? Have you read about cancer surveillance? Anybody? Sino nagsalita din sa prevention and health maintenance? Sila Serna? Si John? Austin? Ikaw ba?
It's me.
Yeah, have you heard about cancer surveillance? Breast cancer surveillance?
No, sir. I only heard about cancer prognostication.
Prognostication. Okay. There are two types of cancer surveillance, two schools of thought. You have the symptom-based directed surveillance, just based on symptoms. The other one is using a battery of tests, no? Okay, a lot of tests that like bone scan, CT scan, no, etc., etc. Okay, so these are the two schools of thought, that you have to consider. You have to advise the patient, no? So the difference between the two is that with the battery of tests, you tend to discover the breast cancer, any breast cancer recurrence earlier than based on the symptoms. Kasi usually, pag may symptoms, medyo huli ng konti, di ba? Okay. But in terms of long-term result, meaning in terms of survival, pareho lang, no? Okay. To the point that those who undergo kasi when you say surveillance, we're talking about yung mga metastases, no? Distant metastases. So those who are undergoing the battery of tests, usually kahit na maaga ma-detect yung recurrence, but they die at the same time as those with symptom directed, no? So in the end, the quality of life will not be as good as those with the symptom-based surveillance, kasi mas mahaba yung yung mental suffering nila kasi alam nila may recurrence, di ba? Okay. Compared to the symptom-based, yung symptom, meron ka nga pero wala kang nararamdaman, tuloy pa rin ligaya mo. And then, before you die, at least shorter yung mental suffering mo, no? Ganon. Okay. So those are the two options that you have to consider, no? So actually the recommendation is really symptom-based surveillance, pero a lot of in this country and other country, because we are driven by laboratory tests, no? Okay. So a lot of these doctors are using, and even the hospitals are using, yung mga battery of tests, no? Okay. And then as to the tertiary prevention, bakit yung clinical breast self-exam is not being recommended? Do you agree? Ares?
Yes. Yes, sir. Yes, sir. It's in screenings, sir, but in screening, it's really not recommended according to the guidelines or according to our literatures. But in patient presenting with as such a mass, of course, clinical breast exam is still important as a component in our physical examination.
Okay. So, kasi we have to go back to the word screening. Screening means wala kang symptoms, no? So you try to do something to be able to detect the breast cancer. We talk about breast cancer early enough, di ba? Okay. So you can do a breast self-exam kasi wala namang symptoms, di ba? Or clinical breast self-exam. When you say clinical breast self-exam, it's done by a physician, di ba? Or a healthcare professionals, no? And then you can have your mammo, the usual mammo ultrasound, di ba? Okay. Ganon, no? So the reason why they don't on paper, they don't recommend clinical breast self-examination. They always use the reason kasi hindi ginagawa ng tao, no? Okay? Okay, so yung saka breast mammography can detect it earlier compared to just palpation, no? Okay? So to the point that they issue a statement that it's not recommended, no? For me, it's not really absolutely tama, no? Okay. Number one, not everybody will have, you cannot force everybody to have mammography, diba? Okay. And yung resources natin kulang din. I don't think all over the world ginagawa yan. Na every year merong mammography, no? Okay. So, especially in the Philippines, hindi natin, I don't think we can implement that. Mammography every so often, diba? Okay. So you just have to tell your patients to do your breast self-examination, no? And then to teach them how to do it and how to interpret, no? So for this particular patient, I don't think she has mammography, di ba? Hindi niya kaya, di ba? So, pero ang unang nakakapanon siya rin, di ba? Kaya lang, huli na, di ba? So to remedy that, dapat turuan siya to do it more frequently, di ba? Okay, and then teach her how to evaluate. No? Okay. So yan ang comment ko dun sa breast self-examination. So, okay, I think that about 5 to 12:30. Okay, 5 minutes. Okay, any questions? Yes? Wala. No questions?
I have a question po,
Sure.
sir. If mas practical po na gumamit ng ultrasound po for breast cancer screening, since it's also cheaper, why is the mammogram po still a gold standard?
At the moment, mammography is the gold standard. Pero at the rate things are going in the Philippines or even abroad, I think, no? I would still go for, okay, between mammo and ultrasound, pwede to be cost effective o kaya baka mas hindi takot yung mga pasyente, no? Kasi yung drawback ng mammography masakit daw, di ba? Okay. So you can use ultrasound, no? The drawback with ultrasound kasi naman ganun din sa mammo may mga drawback din, no? May negative kasi may mga false alarm, saka minsan hindi siya ayaw nila mag-commit, di ba? They will also say BI-RADS 0, no? If you do an ultrasound, I don't think you will be seeing a BI-RADS 0. They will say BI-RADS 2, 3, 4, ganon, no? Nagko-commit na siya, okay? But as you mentioned in one of your slides, it's operator dependent, no? Okay. So maraming false alarm then, no? Maraming false alarm, no? So it depends on who's reading it, no? Kamisan, I have experience with maraming nababasa. BI-RADS 4, what's BI-RADS 4? Suspicious for malignancy, right? Okay. So when I palpate the breast, there's no mass. So nagsa-second thought na ako, tama ba ito o hindi? Na? Okay. So if I have it repeated in another institution, my practice is if I don't feel a mass there, no, palpation, then BI-RADS 4, usually ang recommendation sa report, BI-RADS 4 suggests need a biopsy. Okay? Okay? Palagi niya sinasuggest, go for biopsy. No? Okay? So I don't follow that recommendation right away. I have that patient repeat the ultrasound in another center. Okay? Okay. For second opinion, okay, with telling the patient not to tell the second center that she has an ultrasound done in another center. Okay? So a lot of times it will turn out to be BI-RADS 3. BI-RADS 3, from 4 to 3. I have a lot of these patients now, which I'm trying to help. I mean, I'm trying to advocate also because in the Philippines, but the moment you have BI-RADS 4, my recommendation, you biopsy. And most of the doctors, most of the surgeons now will really run after that because they will say, we have to give the radiologist the benefit of the doubt. We run after it now. Okay. Without thinking that the patient might be undergoing unnecessary biopsy procedure. So I usually repeat, if I palpate a mass, that's the time I biopsy it. No? Okay. But if I don't, I'm not able to palpate a mass with BI-REDS 4, I usually repeat it. There are a lot of false alarm there, no? And the practice usually, just to tell you the common practice in the Philippines or anywhere, there's a tendency to overread rather than underread. No? Okay, so take note of that. No? Okay, any other question?
Sir, I have a question po.
Sure,
It's more,
sure.
I'm curious po. If this patient po cannot tolerate chemotherapy or the chemotherapy wasn't effective po, as surgeon po, how does this affect po the surgical procedure po? Do they go again for chemotherapy or you proceed for the surgery?
Okay, there are two schemes there. You can do a sandwich, meaning you just give part of the chemotherapy first. No, let's say it's supposed to be before it use. There are a lot of regimen. No, one can use one, let's say CMF or one regimen that will run for 6 times, 6 cycles, and then they just give the first 3 initially. If there's reduction of the mass operable already, then we do the surgery. Then after the surgery, we continue on with the last 3 sessions. Okay? That's what we call sandwich, right? So, but in this particular patient, she has completed her chemotherapy. So that's not sandwich anymore. Completed up to the 8. Then we do the surgery. Then after that, we don't have to give chemotherapy anymore. Then, but you can give the hormonal therapy because the patient is ER positive. No? Or if the HER2 is positive, she has to undergo the targeted therapy. Tuloy-tuloy lang. Did I answer your question?
Yes po, sir. Thank you po.
Okay. Any other question? None? Okay. Okay. 1, 2, 3. We have 4 females here. I'm advocating breast self-exam. I want to announce it to you. So I'm giving cash prices for my patients who can do breast self-examination on a monthly basis. Kahit na I'm targeting only 200 patients para give them cash awards of 500 pesos each. Okay. So that kahit na magawa lang nila yung breast self-examination for 9 months, palito, after that, they can develop the habit already. Di ba? Okay. So yung mga babae rito, would you like to join me? You can recruit 5 of your relatives. Ikaw na isa, and then your relatives. Okay. Then I'll give you the primer. Now, how to join the breast self-examination club. I call it a club. No. Then in December, I usually give out the cash award. Okay. Dole out ito, dole out. So last year I was able to give 38,000 to 65 females, no? Mga cancer patients, and then the cancer patients, they have to teach their relatives to do the breast self-examination. Diba? So yon, so ginagawa nila, nakakatulong sila. No? Okay. Okay. So I'll give you the primer later on. No? Basahin lang ninyo. If you want to help me in my advocacy, you can help your family also. No? Okay. Okay. So kung wala nang tanong, let's have a group picture taking.
Sige po, sir. I think I can take the picture na lang po.
Okay.
Sige po, sa'yo na lang po.
1,
1, 2, 3. Smile po. One more, sir. Smile. 1, 2, 3. Okay.
Okay. So, yung link, okay. So the last one, you have to take the ulete. So we have covered this process, interview, symptoms, signs, and then these are the goals. And then clinical diagnostic process, pattern recognition, prevalence. Then you have to come out with primary and secondary. Wag yung 10 differentials, Okay. Then indications based on degree of certainty, and then the effect on the treatment for the first and second, and then you try to select. Okay, benefit, risk, cost, availability. Use this table. You won't go wrong there. Then you interpret the results. Then after that, once you have a definite diagnosis already, you're starting your treatment. You spell out your goal for treatment, and then after that, you advise the patient what will be the goal. Sometimes in breast cancer, you could tell them that we're just going to aim for palliation, no curative intent if it's far advanced. And then you select again, you using the benefit, risk, cost treatment, and then you institute the treatment, and then after that, you advise the patient on how to maintain her health and then prevent the disease. Okay. You can see that there are a lot of advices here. 1, 2, 3, 4, 5. No? So what is lacking in the Philippines, and I think, not to say all over the world, there's a lot of times school lang yung mga advices to the patient. No? Okay. So you can use the table, show it to the patient, and then ask them to choose, and then ask them to sign what they choose. No? Okay, so they have the right to choose what they want. No? Okay. Okay. So can you see the link here? I'll give you the link. Lagay ko sa chat box, Where's the chat box? Okay, can you see the chat box? Can you click on the link? Wala?
We can see it na po.
Lahat?
Iris has sent the link po to the
Okay.
group chat.
You saw the form na, Noreen?
Yes.
Okay, so make sure
Yes,
that you take the Olete, then I'll give you, that will be part of your grade. If you don't if you don't get a perfect score, I'll give you some points, but not the not the total bonus that I'm going to give you. Now, okay, bonus point. Then I'll give you a certificate of completion. Okay. So with that, let's if you have any question, just you can email me, or you can make PM me through Noreen. Noreen is in contact with me. Okay. Okay. Let's call it a day. Bye-bye.
Thank you.
Thank you.
Thank you so much po, sir.
Welcome.
Bye po.
Thank you so much.
Thank you so much po.